All right. I am here today with a really special guest. Chris D is not with us, so it's going to be myself and Alpesh Patel. Alpesh and I have known each other for a long time now. He was 3 years behind me, finishing his residency at WashU in 2004. Prior to that, I think he did undergraduate at Cornell, MD at Northwestern. There's a theme coming. And I would love to talk about this, maybe another podcast. You got your MBA from Kellogg, which is super impressive, and you have been on faculty at Northwestern since you finished your fellowship. You are a well-known and renowned spine surgeon focusing on the cervical spine, as I understand it. And I love to talk anything businessy or life with you. And today we're going to talk about AI. So tell me what I missed. Tell me what you want to add, and
Yeah.
welcome.
Yeah. Thanks so much, Charles. I appreciate it. Are we going by Chuck or Charles? What's your official podcast name?
Yeah, I wanted to switch to Charles as I got older because I thought it sounds more, like
Adult?
adult, but I
Yeah.
can't I can't do it. When I went to business school, I'm like, all right, I'm going to be Charles. I'm going to introduce myself as Charles, and I failed. So I'm Chuck.
Yeah. Okay. I mean, you've been Chuck to me for almost, 24 years, so I'm gonna stick with that one. That's a hard habit to break. Um, but thanks for the introduction. I do appreciate it. I will make one little mini shout out just in that bio is that I did spend 5 years, 5 wonderful years at the beginning of my practice at the University of Utah. And so I
Oh, I
was there,
forgot.
yeah, with Charlie Saltzman was my chair, and he had hired me out there, and I had phenomenal mentors. It actually plays into a lot of my career trajectory, as you'd imagine, right? A lot of things you see early in your career have this tendency to propagate and really push you forward and propel you forward. So I had 5 wonderful years there with Charlie and Daryl Broadke, who's the current chair. And then I came back to Chicago, and that is where I was born and raised. And outside of a period of time at college, then training in residency with you, and then those few years in Salt Lake, I've been in Chicago and affiliated with Northwestern for a large chunk of that time. Yeah, no, I'm excited to talk. We could talk about a lot of things, but I promise you I'll try to keep my answer short, and I will try to focus in on the AI conversation. And we've been doing some great work at Northwestern on AI, machine learning, and how it plays into the world of patient care, specifically around musculoskeletal care.
Yeah, perfect. Um, Briefly, before we jump into that, you are current president, I believe, of the Cervical Spine Research Society, and your meeting is coming up this week, I believe. Is that right?
Yeah, yeah, absolutely. I am the president of the Cervical Spine Research Society. We are a international organization focused on improving the care and outcomes of patients with cervical spine diseases through research and education. And we have our annual meeting actually in Chicago, just about a mile from where we're talking right now. And it should be fantastic. And a big component of that meeting, in addition to the human factor of getting people into a room together to exchange ideas,
Novel.
is a conversation around research, and a large chunk of the research that we see being submitted to the CSRS, to other societies, to journals, it involves utilizing different types of AI-based methodologies, right? And so I appreciate you letting me plug the meeting, and I appreciate the chance to talk about it, but it does overlap quite a bit.
Yeah.
And I think you probably see that in hand. We see that in a lot of surgical subspecialties as well, right?
Yeah, for sure. It's interesting, and I'm not gonna say. I was going to say that it's interesting how research is now far more than just about the nuts and bolts of a surgery or taking care of a patient. There's so much else that's brought into the discussion of research. It's all relevant, but when we started in residency, there was none of this. It was just the nuts and bolts, and now there's so many other things that is real research and really advanced the field. This obviously being one big part of it. Um, all right. So let's jump into the meat of the conversation. And I first heard you talk about artificial intelligence at an AOA meeting, American Orthopedic Association meeting. It's probably been 5 years ago. I don't remember exactly when it was, but it was an excellent, I think it was a symposium, but it was an excellent symposium. and got my wheels turning. I hadn't thought about it a lot before then. I've thought about it a lot since. So let's start with some definitions, easy
Yeah.
ones. What's AI?
Yeah. So these are good places to start, by the way, right? Because I think many people listening, myself included, have heard these words thrown around for a long time. I mean, AI, I heard about artificial intelligence back in the 80s when I was just learning about what computer science was and what basics of research were. I think the best way to think of AI is to think of it as a broad field of computer science, right? So it is a large field of computer science that attempts to create systems and processes that mimic, or I should say, really recreate tasks that human intelligence would normally have required to do. I think the key differentiator here is that we're not talking about a general AI that mimics a human being. I think that's where science fiction takes us. That's where all of our books and movies and have taken us. Certainly a lot of my childhood was watching those movies growing up. So we need to erase that from our conversation a bit. We're not talking about a general sentient AI. We're talking about tasks, tools, processes that we can think of as taking on the tasks that would normally require human intelligence.
Perfect. Um, and how do you think about the definition, the excellent definition you just gave of AI versus a definition of machine learning?
Yeah, that's a good one because you oftentimes, again, hear these used together and used interchangeably. So I would, again, machine learning, think of it as a subset, right? If AI is this large circle, AI, machine learning is a smaller subset of that. It's an example of artificial intelligence. So think of it as a subset of AI that involves basically teaching computers to learn through different techniques using different algorithms. And what that learning means can vary from technique to technique. Some of it's what's called supervised learning, where there's a human teaching an algorithm. There's unsupervised learning, where you have the algorithm sort of teaching itself through iterative learning. Um, and then you've got other examples of that blend the two, right, between supervised and unsupervised. Sorry about that. I'm getting a text from my residents in the morning. Hopefully that doesn't pop up on your screen. So, so that's what I think of ML and machine learning comes in lots of different ways and forms. It has lots of different goals. But generally speaking of it, I would have most people, when we introduce them to the concept, thinking of it as an example of artificial intelligence. It's probably the one that we have investigated the most because it's mostly algorithmic software driven and the availability of those software is pretty widely spent right now. It's pretty widely available. So the limitation there really is in the access to data. Some of the other applications of AI require, I think, a lot more upfront technology, and that's where you won't see it maybe as widely applied yet. It's sitting mostly in the hands of private companies or large collaborations.
So the machine learning that affects you and I, so if I go onto one of the, ChatGPT or Claude or whatever, and type in, what is carpal tunnel syndrome, the machine learning that we get there, is that harvested from web crawlers, basically harvesting as much information as possible from as many sites as possible across the internet? Is that where that information is gleaned?
Yeah, so ChatGPT is one that we all have heard about, right? Like, and I think it's pretty common. I have it on my phone, and I use it probably on a daily basis at this point.
Do you pay for it? Do you have
I,
the $20 a month one?
I pay for it because we also utilizing it as part of our research.
Uh,
So there's levels of depth of it that we need that we couldn't get through it. But for a long time outside of that, for day-to-day life, I haven't paid for it. The searches I'm searching up don't require the speed that we're talking about for a subscription service, nor do they require the complexity. I used it to come up with names for our turkey trot team, that
Right.
offloaded some work from my head, about a month ago. Um, but also for real things around work as well. But ChatGPT, again, it's an example of AI. It utilizes machine learning methodologies, right? But it's not machine learning by itself. There's a large language model behind it. There is some predictive analytics that go into it. There's iterative learning as well. It also does allow you to use voice, right? So there's a sound component to it. You can upload images to it now, so it actually has computer vision baked into it, which is another subtype of AI, right? So machine learning is one component of it. I would think of it almost, and this is overly simplistic, and more savvy listeners will challenge me on this, but I think of machine learning as the some of the gears that go in behind the machinery, if you will, if I use a 18th or 19th century analogy. Um, but ChatGPT is an example of where we see a potential impact of AI applications into us as physicians, to us as patients, right? We're all patients at one point or another. But even to us as individuals, maybe running businesses or running research efforts, is that this is the first large scale, highly visible, well talked about, AI application that we've experienced in our lifetime.
Love it. So, one of the things our listeners are thinking about now, if they're thinking anything like I'm thinking, is, and this is gonna go in all different directions because it's very hard to have a straight line discussion about this. But you may have answered one of my questions, which is which engine, I guess is the right expression, do you use? And it sounds like you use ChatGPT. I've done a lot of kind of trying to investigate, and actually in business school we talked about this. There are a number of alternatives. By your choice, I'm assuming that you prefer ChatGPT over Claude, over Google Gemini, over Perplexity, over Microsoft Copilot, et cetera, et cetera. Did you choose ChatGPT because it's better, or did you choose it because it is what it is? I don't know. Why'd you
Yeah.
choose it?
Yeah, let's be clear on that one. By no means am I advocating for one machine over the other. It was the first one available. It was readily available. So, right, you learn in business school, right? Go to market. If you got first mover advantage, right, you got a big advantage. And I think ChatGPT lives that. It's got first mover advantage. It's got brand recognition, right? So when you think about these AI-based, let's call them assistants for right now, right, or AI-based platforms, it's the one that everybody's heard about. So that's why we use it. You mentioned a couple of the other ones, Gemini, I've used that on my phone. Copilot, we have that available as well. Which one do I go to? Again, I wish I could say that's my day-to-day life, that's driven by a lot of in-depth thought and analysis and pros and cons. It's really like, well, ChatGPT is the first one that comes to top of mind for me. Now, what I would say is from a research standpoint and from a clinical application standpoint, it's a really important conversation to have, right? Which is to say, can we rely on one platform or one engine more than others? And the absolute answer in 2024, as we speak now, going into 2025, is that we cannot. I don't think anybody could say that one of these platforms is better than others. When we look at it from a research standpoint, we have to really ask hard questions, which then inform our clinical applications. Are these really reliable? Right? ChatGPT is sort of a generalized large language model. It may not current state be trained on in-depth medical content, for example, let alone spine surgery content or hand surgery content or the very, very small details that go into our world. There's also, so it may not have the depth of knowledge because it doesn't have the data in, because it does grab data from, I mean, where they get their data from is proprietary. You don't really know for sure. And as the lawsuits come out over the years, we'll find out where the data comes from. But the thought process is that the data was captured through large publicly available data sources, right? Um, but when we think about which of these is best, what you're seeing right now in the market is that you'll see, uh, let's call them AI companies, because that's what they'll market themselves as, but application companies that are solving for very unique issues, right? They are going to come out and solve for a very specific problem, whether that be a specific diagnosis in our language as physicians, a specific procedural solution, a specific thing. They're going to be hyper specialized AI platforms or systems rather, not generalized platforms because they're limited on their data that puts in. And AI, ML, what we've seen from our work at Northwestern is that it's your data in drives the quality of the outputs, right? If your inputs are marginal or questionable or inconsistent, your outputs will be so there as well.
Love that. Again, I'm zagging a little, but touching on something you said um, a year ago, because things are moving very, very quickly. we heard a lot about one of the limitations. You mentioned one of the limitations being access to knowledge and in-depth information and things like carpal tunnel syndrome. One of the other limitations was the risk of incorrect information provided with a search, and that some would label hallucination. So I might type in, what's the best way to treat carpal tunnel? And the response may be rotator cuff repair or something just completely bizarre.
Mhm.
Um, what's your sense of the state of the quality of the information that we receive back from a query?
Yeah. I think and again, it depends on the question that's being asked. If it's a very specialized or specific question, I think you still need to be very skeptical of the answer. If it's a general question, you may find that the answers are fairly accurate and fairly reliable. And you may find that the more you ask it, the better it understands what you're looking for, right? So a lot of this, some of this comes down to the prompts, the asks that we put out there to these systems. And we have to get better at asking better questions, maybe. But some of it is also the actual data in. And the example I'll share is we have a research project right now that we're submitting. So that this is not peer reviewed yet. This is just going into the peer review process. But where we compared, for example, 3 or 4 different engines looking to do a systematic literature review, right? So you remember, Chuck, when we were residents, we would do these systematic reviews. Our job would be to scour the literature and then look for every peer-reviewed journal we could find, look at all the references in those peer-reviewed journals, and keep digging and digging and digging.
And walk to the library to do that.
Yeah, yeah. I was trying not to date ourselves that much. I do think we had a computer to search on, but nonetheless, you would do that iterative process, right? So if you think about a human task that might be replicated by an algorithm, by machine learning algorithm, part of an AI platform, yeah, that seems like a repetitive human task. So let's see, let's compare. So we actually compared our residents doing a systematic review on a specific topic in cervical arthroplasty and cervical fusion surgery. And we compared that to 3 or 4 different models, one of them being ChatGPT, so the other 3 being more specific, sort of medicine or healthcare specific models. And what we found was that there was a fair amount of overlap that we found a lot of the articles that the humans found, which was cool. We like that's always feels good. There were some articles that our residents found that the algorithms couldn't find. But then there were articles that the algorithms found, and ChatGPT in particular found that not only we couldn't find, they actually don't exist. Right? So
Oh,
we identified a number of articles that were suggested to be actual review articles, actually not review, but primary sources of information to include in a systematic review that actually don't exist. They've never been published. There's no authors of that name, and there's no papers of that name. So that's an example where an output in a hyper specialized question you have to be very skeptical of, right? Very skeptical of. But when I asked ChatGPT for, a recipe for a really good, old fashioned, it does a pretty good job of coming up with a good recipe for an old fashioned. So I think we as orthopedic surgeons, we as researchers need to temper our expectations from these products for now,
that's
not run towards some finish line. And then we also need to be really good advocates for our patients, right? As always, we want to educate and advocate our patients, and they may find themselves with these technologies in hand, expecting them to be sources of truth, right? And so we
for
need to be
sure.
able to explain to them not just what a reality might be, but why they may not be able to put all of their faith in that platform yet.
I'm gonna pat one of our med students on the back. I think my second AI sort of related research, and Carrie Reaver, who's now a second year med student, did an amazing job. It's been accepted for publication in JBJS, which is awesome. Looking
Yeah.
at the readability of online patient education materials
Yes.
in English and Spanish, assessing how ChatGPT did.
Yeah.
And reading level and all that stuff. So there's so many directions. This is an example of a paper that wouldn't have been published when we were residents, but there's so many different important things to do, and different directions to go using ChatGPT. So you're doing really cool stuff. This is a little bit of low-hanging fruit, but I think important.
No, I think it's really important, and I think that's an example right there, Chuck. And we've looked at a similar thing, which is to say, hey, listen, we've invested a lot of time and effort into this patient education content materials. Is it readable? Is it understandable? And we're finding again, and this is where a machine learning program has helped us get through that process faster of understanding it. Same things, right? It gives you a lot of insights.
Yeah.
So that's an example of where we can take these tools and actually use them for a very specific question, a very specific purpose, a very specific output, and rely on them, right?
Yeah.
So they're hyper specialized tools. And
Yeah.
that's where we're successful. When we treat them as general tools, we start to see limitations fast.
All right. I think one important thing to mention for all the listeners is, how do you handle HIPAA and important patient-related information? So I'll tell you what we do. I'd
Yeah.
love to know what you do. So we have very specific guidelines at Washington University that I think are pretty well thought out. So I cannot take patient information or a Excel spreadsheet and use ChatGPT as publicly available, but we have a protected playground environment it's called WashU ChatGPT. And in that environment, I can do whatever I want because it doesn't go out, it only comes in. So that I can do and can't do. We're on Zoom right now. The Zoom AI tool we can use. The Adobe AI tool we cannot use, and that's been turned off. What other examples, or how do you think about that, or did I capture a good amount of it?
No, I think that's a really good example. I think everybody, whether you're sitting where we are, which is inside of a university system, right, which has a lot of processes in place for data protection, data privacy, patient privacy. Sometimes I find myself trying things out, wanting to try things, and I'm told we can't do that. And while I'm frustrated at time as a researcher, I also understand why we have these constraints, right? Because there is a massive privacy concern that comes with it. If I'm in a smaller group practice, let's say as an orthopedic surgeon, right, or in a private company or small company, this is something that you really need to spend time thinking about, which is what are your security measures going to be? And I think you're finding obviously AI companies that are solving for that. That's the beautiful thing about capital markets. If there's a problem, you're going to generally find a solution. But yeah, we have the similar kind of constraints. Northwestern, for example, has a strategic partnership with Microsoft. And so that gives us some degree of freedom to work within a constrained firewall, if you will, for lack of a better term, around Copilot, right?
Yeah.
And when we work with other algorithms, what we're doing is making sure that all that work stays internal, that we're not actually actively sharing any of that information externally. That's something that, again, 10 years ago when we started this work on predictive modeling, that was never a conversation,
No.
right? And so now it thankfully is a big part of the conversation.
One of my it's not a fun example, but just how careful we have to be. There was a plastic surgery group in town that was posting pictures with, patient privacy pictures, but they were unlabeled. Patients were really hard to identify, but there was metadata
Yeah.
associated with the pictures with patient names, and it led to a massive lawsuit. The message being, we have to be really careful here.
Yeah, no, for sure. And again, there's a lot of these anecdotes, right? There was a story or there was an example of uh, a group that took, just to demonstrate the privacy risks that we may not be thinking of, that took LinkedIn images that physicians had posted on LinkedIn that had any kind of an X-ray or a CT scan of the head and neck. And they were able to take that data and using an AI algorithm,
You're scaring me.
recreate faces of the people who were supposedly de-identified, anonymized, and they could recreate faces of who they think these people might be. And now you may argue, well, they aren't accurate, it can't really do it. But the idea is, we're not that far away then. If the first go is not that is an idea in that direction, you'll iterate and you'll see people figure it out. So even things that we think are anonymized, we really need to ask, twice and ask thrice and really find, like you said, firewalls that protect our ability to try things out from, unintended consequences.
Absolutely. I want to ask you one question, which I think you could probably talk about forever, but I'm going to ask you to keep it brief because I want to get to the medical applications of AI.
That's of course, yeah.
let's say you're doing a search and you're on ChatGPT and your query is, what's the best way to treat cervical pain? I don't know, something. Explain to the listener that, I hope I'm saying this correctly, that this is not a one question, ask ChatGPT and walk away with the answer. Explain how you question and then refine your interaction with ChatGPT to get to the answer you need.
Yeah, no, that's a good point. So from a research lens, we oftentimes ask one-off questions because that's the research methodology, right? And so you have to think about it in the real world application. It's not a one-time game; it's a repetitive interaction. So again, we when we look at how these models function through their interaction with us as end users, as humans, right? And this speaks to a bigger issue, which is that in current state, AI applications are really meant to augment us as people, not to replace,
Right.
right? So if they're augmenting us, they're helping us with knowledge, decision making, insights, predictive modeling, whatever it might be, but they're augmenting us. So it's our interaction with these platforms is really important. So what's the iterative prompt, right? How do you get really good at prompting the different platforms to get you the knowledge that you want to get to? At some point, not to get too meta here, at some point, there'll be an AI platform that does the prompts for you, that will iterate your prompts for you as it gets to know what you're interested in, right? So that you can ask a relatively simple question and the AI will figure out what you're really asking. But we're a ways from that, right? We're a
Right.
ways from that, probably in a good way, that we have some barriers there. So it is a matter of asking again. I think the take home is if you want to interact with one of these platforms, ask a very specific question. Know what you're looking for. You yourself should know what is it that I'm really trying to figure out. Does surgery help cervical radiculopathy? Right? And if so, how often, how frequently, what can predict a successful outcome versus not a successful outcome? Now, I would argue these are questions right now that as a patient, I hope they feel comfortable asking me. But in that, compressed time that we have with patients in the office, we may not be able to get to the depth of the question. The patients may not feel at ease, oftentimes asking these kinds of very, very specific data-driven questions, or they may not even know what questions to ask, right? So that's where an assistant like this can give a patient information, if I'm being very optimistic here, information at least with directionality, right? It may not tell them the final answer, but it gives them an idea of what direction should I head in, what kinds of questions should I ask, what kinds of things should I be looking for. And that's how I try to educate my patients on how to interact with these platforms.
Yeah, it's we hear a lot about the number or the percentage of patients that walk into the office having interacted with the internet. And by internet, traditionally we talk about Dr. Google.
Yep.
And I think in St. Louis it still is Google, but that is going to change pretty rapidly, I think, to interactions that are with ChatGPT or others.
It is. And
So
even right now, Chuck, if you go to Google today, the first thing that pops up is a Gemini answer,
that's
right?
exactly right.
So even if it is Dr. Google, it's still going to be a lot of it might be informed by that top line that people see, right? Which is this is Gemini's answer.
Yeah, that's a great point. All right, let's get to the meat of this discussion.
Yeah.
And I knew this was going to be a time challenge, and I know we talked about keeping this to 45 minutes. We'll see. This is great stuff.
If you
So,
want to do a part two, we can always do a part two on like the in-depth applications, right? Because that's I think a lot of times what people are wondering is what's out there right now, and do I need to incorporate this into my clinical practice? What is it going to look like in 5, 10 years, right? Like,
yeah, that's
so
actually a good idea.
I'll let you lead the store. I'll let you lead
Yeah,
the way. Yeah.
yeah, we'll see. We'll see what we can get accomplished and what we feel like we left
Yeah.
on the table. So, I'll start with a broad question, and then we should obviously take it to a different level. Tell me how you and how Northwestern is incorporating AI on a clinical and educational perspective. Maybe not so much the research lens, but clinical and educational.
Perfect. Yeah. No, I'll speak mostly for myself. I will say what we think, what we're doing within orthopedic surgery and spine surgery at Northwestern. I'll give some examples of what we're doing at a hospital level. But I would caveat and tell everybody this is still relatively nascent, right? Like we in academics and in large healthcare systems are usually not first to market to move towards things, right? So
Yeah.
we're taking this a bit slower than you might see in the private world, right? In non-healthcare applications. So how do we use this? So there's a couple of things. If we think about clinical work and we think about who is a technology going to benefit, is it going to benefit a patient or is it going to benefit us maybe like as this physician, surgeon, healthcare team, right? So if we think about it as us as surgeons, I think many of us, many people listening may already be utilizing some degree of an AI-based technology without necessarily overtly thinking of it as AI, right? So one example would be is if you do any kind of preoperative planning and if you use any kind of software for preoperative planning, which in the spine world is, again, still relatively nascent, but we're moving in that direction, right? Um, we work with one company that uses AI technology to design custom-made patient implants for spinal surgery that help guide us towards or lead us towards more reliable, consistent outcomes, right? Surgical outcomes in terms of spinal realignment. That's just one example that is an AI-based technology that is already in real life, already being utilized.
Yeah.
Maybe not at scale because there's some cost issues there still, and we still need long-term outcomes to know if we're making an improvement. But that's one example, which is like pre-op planning. We think about, another example for a patient-facing lens, is around education. We talked about this earlier, right? Can we do things to make patient education simpler and more reliable? And so one thing that we've tried, and it is research, we got to see if we can roll this out, is to take this one problem, which is MRI reports, right? I'm not sure if you have this in your practice. I know I have it in mine. Many of our partners do, which is that our patients will nowadays have ready access to all of their healthcare information.
Yep.
Wonderful.
Yep.
I mean, that level of transparency is fantastic, but all the information in there is not at a level of readability that most people, even the most well-trained, well-educated person, may not be able to understand it. And they'll come in with their MRI report in hand, a highlighter in the other hand, and then just highlights everywhere on the
So
MRI.
true.
So we're taking these large language models and a couple different algorithms and trying to convert that language into something that an average person in the United States, whether that be fifth grade or eighth grade reading levels, can understand.
Yeah.
Right? That's a patient-based application that we'd love to see if we can roll out.
Awesome. Those are two good examples. Let me ask you some more specific ones.
Absolutely.
So, when you see a patient in clinic, uh, do you dictate your note? Do you type your note? Are you using an AI assistant to create your note? What are you doing now? And then I'll
Yeah.
tell you what I'm doing.
Yeah. So what I do is I dictate a note using an application. That application has been, since the time we started with it, been bought and sold, and is now sits inside of Microsoft. And they take that recording, and it used to be that that recording was sent to a person to transcribe. And I'm fairly certain now that that recording is transcribed by an AI algorithm,
Oh,
right? So we get it back. We are trialing a ambient listening technology, right, that listens to the conversation and creates a structured note out of it. We're in a trial mode there. That's again another partnership with Microsoft. What do you do, Chuck? What do you do in your practice?
if I'm reading between the lines, and I never shy away from, getting to the kind of specifics, it sounds like you're trialing DAX Copilot. Maybe you are, maybe you're not, but we did a trial using DAX Copilot. And for those who aren't aware, DAX is basically Dragon, which was Nuance, which was purchased by Microsoft. And I have to say, when I trialed it 9 months ago, it didn't meet our needs.
Right.
And so now we are trialing a bridge technology. And just for those who aren't aware, I may have mentioned it on the pod, I'm not sure. But basically, what happens, and a bridge is great. We're moving on to the second phase, and we're going to start purchasing licenses. But it's another cost center, another overhead generator. But the way a bridge works, which is the same way Docs Copilot works, is I have to open my Epic application on my phone. I put the phone in the office. It listens, it records, and usually within 1 minute, I have a note which has been generated. So it takes a conversation and it reorders it, and it's super impressive. I would say the
Yeah.
HPI and the assessment and plan are 95% amazing. The physical exam really depends on me awkwardly verbalizing what I'm doing, and
Sure.
it's super awkward. So a bridge for me has been a game changer.
Yeah. I think that's a great example, Chuck, of how not only do our technologies iterate, but we need to be able to iterate, right? In our practices. We need to be able to be critical and say, hey, you're there, you're not there yet. I think that, but that's just an example of, gosh, I mean, I will tell you, like, I don't know a single physician who loves documentation. I can't think of a single person who says, I can't wait to go out and document today, right? And we know the implications, like we know the downsides, right, that this has had on the profession in terms of,
Be specific there for a second. Yeah. What are the downsides that
yeah,
the documentation burden?
yeah, I mean the burden, it's not so much the idea of documenting. We've been documenting for generations. We need that. That's how you remember what happened in the past. It's how you guide the future. You take implicit ideas in your head and you make it explicit in writing so that you can remember and that others can pick up for you, right? If you're not there. There's a fundamental purpose of documentation. What's happened though, right, in the last 15 to 20 years is really that the purpose of documentation has pivoted, right? And it's no longer about patient care. It's about coding, right? And it's about coding to the maximum amount you can while also meeting all the regulatory requirements. So you layer in those factors, and now documentation goes from a useful tool to a burden, and that burden gets magnified. How many patients a year do you see, Chuck?
I see 60 patients a clinic times, 50 weeks a year, and occasionally some other clinics thrown in.
Well,
So
let's say three thousand.
yeah, that's 3,000, but it used to be 4 to 5, but I've cut back.
Fine. Yeah, you're more important now, so you can speak to people. So I'm right there. I probably see about 3 to 4 thousand people. We've got some of our partners that are in sports medicine that are seeing 8,000, 9,000 people a year. And then we think about our primary care docs who see maybe they may maybe have a panel of 2,000 or 3,000, but they're seeing them so many times. That's a ton of work. And that is time and effort that takes away from us talking to patients. And I think beyond the fact that it just sucks to sit at a computer is the idea that we're actively being robbed of time that we could be spending with a patient. So this is we think it's a driver for a lot of physician, if you like the word burnout or don't like the word burnout, or if you think it's an injury or not an injury, but a lot of the dissatisfaction of being a doctor oftentimes it pretty consistently comes back down to this documentation issue. So if you can take an AI solution and make that more, make it simpler, make it more reliable, right? And make it somewhat automated so it's happening in the background. That should make things better. I'm trying to imagine in my skeptic's mind, how does that make things worse? Other than an accuracy issue, what is it that would create in terms of a negative? And it's really net positive.
Yeah, I think that's all really well said. I do think I'm going to add to what you said, and you can correct me if you don't agree, because I'm not trying to inappropriately add. So first of all, yes, when we dictate our notes, it's all about coding. It's also about cover your ass and medical legal.
It is.
And it's always been that, but with electronic medical records, they don't have to interpret my handwriting to assess, what I may have said. So,
Sure.
and that's good. And the second thing I'll say is it's very clear that the documentation load, especially for those in primary care specialties, does increase the dissatisfaction with career choice and the word burnout, as you said. I would say my experience with these clinic dictation assistants is incredibly positive. And I find that what we all don't like is if I go to my primary care, who I really like, I'm sitting here and he's sitting here typing on his computer. And that's miserable. No one likes that. With this tool, I'm having a great direct conversation with the patient, not writing anything. And so the connection with the patient is markedly improved. And the price of this technology is not a huge burden, but it comes with, at least the way we're thinking about it, is if I'm going to pay, and I don't, some doctors have scribes, and scribes are very expensive tools. This is far less expensive, but it's still another cost. And I better see one or two more patients in clinic to cover that cost. And that's just what medicine does. Every layer we add brings an expectation we need to generate more revenue. Is that off base, or what do you
No,
think?
I think listen, I totally agree with you. I learned when I was your junior resident to always agree with you, right? So what I would add to that though is yes, you want to be able to offset the cost, right, that you're adding to your practice. There's another component which when you're running a business, right, and you're running a group, which is the idea of like, can you hang on to talent, right? So you may say, listen, yeah, this is an additional cost, and if I ledger it and I line item it, how do I balance it out? Is this going to make my physicians, my surgeons, my nurses, my MAs, PAs, PTs, is it going to make them more likely to leave me or less likely to leave me?
Yeah,
Right? So talent retention, acquisition and retention, I think needs to be added to that mix that you just threw in there, which is, hey, listen, it may not give me that time to see an extra patient or two, but gosh, you know what it does? It makes my partners really happy. It makes my nurses really happy. It makes my PTs really happy. And so we're going to make this as an investment because it helps us for retention,
it's
right?
really
That's just another example, right, of where you might find the application of these technologies beneficial to your clinical practices. And we see this being mirrored in non-healthcare industries, right? Chuck, you and I talked before about the benefit of getting an MBA is, hey, you get a chance to see what life looks like outside of healthcare. Um, and you see this applied pretty widely already, right? In a lot of different fields, especially in retail, consumer goods, those kinds of things. And the workforce component is a large part of that, right? It's a large part of their decision making is not just can I get more productivity or can I reduce labor? It's also can I hang on to talent?
really, really good and important point. All right, I'm going to put you on the spot and maybe make you feel uncomfortable. And I'll start by saying I have done this. Have
Yeah.
you ever seen a patient walked out of the room being a little uncertain about what the diagnosis or the most appropriate management might be, and gone to ChatGPT and said, "Help me with this. I have a patient with X, Y, and Z. What do you think?"
So I haven't yet. I'll be honest with you. I have sat there and I've scratched my head and I've wondered, would this be a useful application of ChatGPT? But then I go back to the research we've done and I say, listen, I can't rely on it to make a decision. So what do? I fall back right now into old habits, which is I go back and I look at the literature, I do a PubMed search, and I look for relevant articles. Now that's time intensive. And so, yes, would I eventually love to automate that? I would love to, but I've got to really come to a level of trust, right? On the sources of data that I'm using, whether it's directly myself or indirectly through a platform. And I'm just not there yet.
Yeah, I would say that's a really important point for all the listeners is, maintain a healthy skepticism. For me and my little world of congenital anomalies and syndromes, if
Yeah.
I have an undiagnosed patient, putting a constellation of phenotypes or appearance issues can be helpful, but that's more, add up a number of factors and help me understand. So very different than a true clinical intervention scenario.
So Chuck, I would actually, can I ask you a question? I know that
Yeah.
I'm your guest and you're the host, but so have you ever taken or thought about taking an image of a hand anomaly and putting that out there, just the image, putting that out to the world and saying to a platform and saying, what is this anomaly and can you detect it through a computer vision application?
Yeah, it's a great question. We have not done that. We have talked about that as a next research step,
Yeah.
because it is a great question. Because I'll give an example. I had an amazing young family come in the office last week with a child with a congenital difference. And, what we do now is you and I and anyone who's seeing a lot of patients, no matter what the potential diagnoses are, we're just sort of doing pattern recognition. Well,
Yes.
pattern recognition is exactly what this is. And I didn't know what the diagnosis was. So in our research group, we have the Code Registry, which is really an amazing platform. And so if we don't know the diagnosis, we check a box and our classification committee considers it. But your point is excellent.
That's a great structure, by the way, to have in place. And I would commend you to be willing to put it out there to the world that sometimes, and you're not going to say this, but you're one of the nation's experts in congenital hand differences, right? In
Thank you.
anomalies. And for you to say, yeah, we may not know sometimes, and I'm willing to check a box that says, I don't really know. That, by the way, itself just speaks to like a learning environment, a growth mindset, all these super positive things. I also will say I appreciate your use of the word difference as opposed to congenital hand defect, which I think is what it was called, right, when we were in training. So
Yeah.
no, I think that's a great application of it. So I haven't used it. What I have done though with patients, because sometimes we're having a conversation, and even if I'm not dealing with the level of rarity or uniqueness that you are, there are times where I will be talking to a patient about a condition, and it may be a cervical radiculopathy, a lumbar radiculopathy, it may be cervical myelopathy, some really common conditions for us as spine surgeons, but obviously brand new to the patient. And I will just ask them, I said, hey, can I have your phone real quick? Let me type in the condition so that
That's
you
awesome.
can start to figure out what to read about on your way home or when you get home. Um, I'm not sure if our phones are actively listening to us or not. My
They
as a
are.
layperson, I think they are, but I can't count on that. So I give them, I sit there and I'll type it in for them, right? Whether it be into, it's usually Google. Um, and I say, these are the things I want you to read about, or I will specifically send them to, surgical videos that I've vetted already. So that's the depth of interplay right now that I am comfortable with patients in general. I have had patients of mine that are coming, whether it be from Northwestern or from one of our other teaching institutions in Chicago, who come from a computer science background. And then it's a very different conversation, right? Because they're interested in this, I'm interested
Yeah,
in this. But I try not to, I try to have a mental barrier up where I'm trying not to let it influence my decision making because I just don't know if I can rely on it or not, right? But you said a couple things. Pattern recognition, like these are broad concepts, but what does an algorithm do that we're already doing? How does a computer take what's implicit in our head and make it explicit, right? To the
right.
world. Pattern recognition is one. You do predictive modeling in your clinic all the time, Chuck, right? You're looking at a patient, you're looking at their diagnosis, you're looking at the structure of their hand, you're looking at the parents, you're looking at the kid, and you are putting all those factors into play to try to predict an outcome.
That's right.
And that's essentially what a machine learning program is trying to do. If you do a predictive modeling program, it's taking data out there and try to predict an output. The one thing that it can do differently is that it may find factors that we can't even identify, right? And that's the cool part. But the hard part, and this is actually what led us to that AOA symposium to go full circle, was that we don't necessarily, how do we interpret the output if we don't understand what the inputs are in a machine learning model?
Hmm.
And if it's truly a black box, if machine learning and all of these applications to us are a black box, and we all we see is the output, but we don't know what's going on the inside. We don't know how the sausage is made. That's a problem because then we can't be critical of it. And I think that's what led us to the AOA symposium was we thought, listen, this is growing in our research, it's growing in our clinical applications. Most orthopedic surgeons were not raised in this world and don't have the level of critique or critical thought, critical tools, I should say, to apply here, and can we move the needle there, right? We know how to look at a chi-squared analysis. We know how to look for a regression, a basic linear regression model. We know what the pros and cons are there because we've seen that over and over again. We need to get to that same level of comfort with some of the AI processes.
I love that. I'll tell you where my brain went, and then I'm going to ask you to sort of close us down by listing a few other things either you guys are doing or thinking about doing, and maybe that's a teaser for a follow-up if you're willing. Where my brain went during your conversation was I imagine this, University of Chicago or Northwestern-based computer science expert coming in your office with, cervical radiculopathy, and you sit down and you're like geeking out on this with this person. And all of a sudden, your clinic is totally off the rails. 30 minutes later, you're still in the room and you're like, my day is shot, but you're super having fun talking about this stuff. Because clinics go off the rails in so many different ways.
Oh,
But a great conversation with the patient, sometimes it makes it okay.
no, by the way, I think it always makes it okay. Now, if you're my next patient, you would not agree with what I just said.
That's right.
But if you're my current patient, I think you do, right? And it may not be just the computer science issue. It may be more a matter of like, listen, as we know, we had some great mentors, right? Like, and so we got to see if your patient feels heard. I think the number one complaint we hear from a patient, and in my practice and many people's practice, is that the doctor didn't listen. No one listened to me.
Right.
And that might be because we're click clacking away on a keyboard the whole time. It might be because we're already thinking about the 30 minutes I'm behind, the 45 minutes I'm behind. But if you have a way to connect to somebody, and if it's through something that you have a passion in, yes, I do find myself stuck in those conversations. I can usually tell I'm in a rabbit hole because the resident that I'm with or the fellow that I'm with, you can see them take their phone out slowly and start to be looking at their phone a little bit. But then I also have a great team, and my team, fights hard to keep me against me to keep me on time.
The funny anecdote, and I think that this has been said on the podcast, that you and I both learned from one of my current partners, Marty Boyer, that 90% of the time the patient walks in the room and within 30 seconds, within 10 seconds, we know the diagnosis. And so Marty will talk to the patient about their pot roast for 5 minutes, and that's the connection point. And we laugh at him in his notes talking about the pot roast, but of course he got it right. I mean, he really has a way with most patients to connect in that regard.
Yeah, and this is a whole nother conversation, which is that example you just shared, the ones that you probably have from your practice and how you connect with the kids and their parents, right? The way we try to connect with our patients at Northwestern, that is all about building trust, right?
For
And
sure.
I will bring this full circle to the conversation around AI. So the issue here is, I think forever and a day, we've believed and we've lived in a healthcare world where people have trust. Like they come to the door trusting us, right? I think that level of trust is really in question right now. And I think some of that level of trust being questioned is justified, right? And some of it is probably a very emotional driven questioning based on what's happened in the last couple of years, right? So, but that ability to create and generate trust is still something that we have as humans that I don't know that an AI algorithm or an AI application is going to be able to replicate or replace. Now, that can be challenged for sure, right? Like I trust my Google Maps to tell me how to get home, like to cut through Chicago traffic, what's the right way? I have trust in Google Maps to do
That's
that.
very true.
If I'm searching on Amazon for something for my kids for Christmas, I trust that Amazon will show me their algorithmic process will show me things that, you know, that 11-year-old boys or 15-year-old boys like, right? Hopefully it's all safe for work stuff on the 15-year-old boy side. So, but I think healthcare is different, right? And I think this is the fundamental question when we think about long-term application of AI technologies when we're talking about patient-facing applications. Back office stuff, revenue cycle management, marketing, regulatory, contracts, finance, that we're going to get to very, very quickly if we're not already there in some practices. But patient-facing ones have to begin and end with trust, and that's still where we come in. And hey, you know what? If that automated scribe you described gives you 5 minutes in the room to talk about, what a patient's going through or to talk about their job or their interests or whatever, great, because you're
That's the win.
building trust. That's the win. That's where a surgeon working or a physician working with an AI technology is a better option than a surgeon working by themselves or an AI technology working by itself, right?
Yeah.
I think that's where we go. This idea of human machine intelligence being a combined effort, not a competitive one.
All right. We really do need to close it down. So I love some of the back office stuff you mentioned, the coding process, which we hire coders who are wonderful, but you can see the writings on the wall where the future lies there. Tease us with a couple other things either you're doing or might be doing in the future.
Yeah. So on the back office side, there's so much to talk about. And that's again, not surprisingly, where you see a lot of the early technology being applied already,
Yeah.
right? So we can talk about that anytime. That's probably more of a business school conversation, but hopefully a lot of the physicians listening care a lot about that as well. I would say from the surgeon facing side, where our research is going is around trying to get to better predictions of outcomes, right? Can we utilize machine learning insights to get to better predictions so we can better inform our patients what to expect, let's say after surgery or after treatment, because then that might affect their decision making, right? All this
Yeah.
comes down to supporting really good decisions in healthcare. We want to think a little bit about patient education. I mentioned earlier one example of how we're trying to translate medical or radiology as a language into patient-facing language, English at a right reading level. And then how do we use AI technologies to better communicate with patients broadly? I think these are some of the things that we're working on from a research standpoint that I'm super excited about. And I think about the next 5, 6 years for our research efforts. That's the fun part. And then there's some really, really tangible applications to solve problems for patients.
Love that. Look, I've taken an hour of your time, and we talked for quite a while the other day in preparation for this. This is gold, and I think our listeners will agree. But yeah, I'd love to circle back and go into more depth. Tell me who your most important partner is with your research and moving this field forward.
Yeah. So I'll name one person. Sri Divi is one of my partners at Northwestern. He joined us in 2020. He's leading our machine learning and orthopedic intelligence um, process moving forward. And he's fantastic. I'd love for you to meet with him and consider, having him jump on. He's really been the human engine behind our machine learning work. And then again, more broadly speaking, though, we are just a couple of researchers in a really large institution, and we're lucky to have really great colleagues and with a lot more depth of expertise in computer science. And then the last group I'll say is actually our students and our residents
Oh
that
my
are
God.
working with us, right? We have and Sri has helped develop this. We have this immense pipeline of talent going all the way up to the undergrad population at Northwestern who are deep into computer science and data science. And, I have to, whenever they talk, I'm so blown away by how bright these students are. I also need to stop and take notes. So I go home and I figure out what they're talking about. But they've also really been an unbelievable source of ideas and talent, for us.
Love it. Love it. All right. Thank you for your time. I look forward to continuing this conversation, and good luck with your meeting this week.
All right. Thanks so much, Chuck. Thanks, everyone.